Today our talk is on central venous recanalization, and the talk will be given by Dr. Chidubem Ugwueze. He is originally from Nigeria, but currently is working at Dota Hospital. He's an interventional radiologist and assistant professor, Dota Department of Interventional Radiology. And also he's an assistant professor of interventional radiology, School of Medicine. You are warmly welcome, Dr. Chidubem.
Thank you. Sorry for the technical difficulties getting on the video this morning. I'm going to start sharing my screen. I approach kind of like a kind of interactive way of doing lectures. So if at any point during the talk you have any questions, feel free to interrupt me and ask your questions. Okay.
Okay.
Can you see my screen?
Yes, we can.
All right, so like one of us mentioned, my name is Chidubem. I'm one of the faculty at OHSU, the Department of Interventional Radiology. In my second year of practice, I was just in Tanzania with Mona Boss and the rest of the crew last month, and it was a great trip. I'll be talking, this is kind of like a big topic to cover in a short period of time. I'm going to try to go through it as fast as possible, especially given that we're starting a little late. But kind of give you like a general broad overview of like the disease process, the technical aspects of treatment and post-treatment management of these patients, and also kind of a brief introduction into like the upcoming clinical trials that will give us a better understanding of how we manage these patients. So just a brief overview, like central venous obstruction. So central venous obstruction is basically a stenosis of any central vein in the upper or lower extremity. And this can also include the renal arteries that results in clinically significant symptoms. In the upper extremity, it can be an occlusion of the subclavian vein, the brachiocephalic vein, or the superior vena cava. In the lower extremities, it's the inferior vena cava or the iliac veins that can be occluded, leading to either symptoms within the pelvis or symptoms in the lower extremities. Pretty straightforward. Most clinical symptoms come directly from the obstruction and venous hypertension. Basically, if you have venous occlusion, the blood return to the heart is impeded, and you create increased pressure within peripheral to that occlusion. The body responds by creating collaterals to try to get around that occlusion to get back to the body. If you create enough robust collaterals to decrease symptoms, then you can actually be symptom-free. However, most people, after a while, those collaterals are not enough to kind of carry all the blood coming out of the affected limb, and leading to symptoms kind of like swelling, pain, ulceration, etc. There's a clinical classification for symptoms for venous occlusion called the SIP classification, which basically goes from class 0, which is basically no symptoms and no findings from venous disease, to class C, to class 6, which is basically post-thrombotic syndrome with venous ulcers. The mainstay of at least the class 1 to like class 6 symptoms is either high-grade compression stockings, or in the case of varicose veins, you can do sclerotherapy or like venotomies and etc. However, once you get to you try to avoid getting to like venous ulcers by compression stockings, or if the patient has some underlying cause, such as like a deep venous thrombosis, treating that as early as possible, especially if it's the thrombosis is in the iliofemoral vein. Because at the point where the patient has venous ulcers, it's pretty difficult and hard to treat those ulcers. Well, as mentioned earlier, I'm going to split the causes of central venous obstruction from the upper extremity and the lower extremity. For the upper extremity, the most common causes are actually foreign bodies, including like central venous catheters, pacemaker leads, and defibrillator wires. Some classic upper extremity central venous occlusion that you're going to encounter on board exams, because you guys are going to be tested on this, because they're very characteristic and they have a very specific algorithm for treatment, is something called Paget-Schroeder syndrome. So Paget-Schroeder syndrome is when there's external compression, of the subclavian vein at the costoclavicular junction. Basically, this compression happens when the patient has their hand elevated, and the abduction of the shoulder causes there to be impingements of the vein between the clavicle, first rib, and the costoclavicular ligament. As you can see on this venogram on the bottom right, the first image is an image of the right arm, like of a brachial venous venogram, showing nice flow through the subclavian vein towards the brachiocephalic vein and superior vena cava. However, when this patient raises their hand or abducts their hand, you see that this flow is impeded because there's impingement and narrowing of the subclavian vein at the junction between the clavicle and first rib. The treatment for this is actually, the first line treatment is a first rib resection. So when you see this finding, you should not be tempted to plasty. Like, that's not the first step. The first step is to if this lesion is causing usually they present with deep venous thrombosis of that extremity. The first step is to do a thrombolysis. You drop a catheter there and lyse the clot. And once you lyse the clot and find that the cause is Paget-Schroeder, the next step is to refer them to a vascular surgeon who would do a first rib resection. If there's persistent narrowing there after the first resection, then you can proceed with angioplasty and possible stenting. The reason why we don't plasty and stent as a first line is because angioplasty, even angioplasty alone in this location, can cause inflammation and lead to worsening of the impingement. And stenting, of course, it will be very difficult. It's technically easy, but but difficult to maintain, because the impingement that occurs at that juncture can fracture the stent itself and lead to worse complications. However, once the rib is resected and there's still residual stenosis, it's more amenable to angioplasty and stent placement. And of course, there's neoplastic causes of thoracic outlet syndrome. So basically, if you have a lymphoma or a lung cancer around the bronchus that's invading into the superior vena cava, you can have a compression of the superior vena cava and thoracic outlet syndrome or symptoms. The management for that is, if you have a lymphoma, is to first try to and the patient is relatively stable and not too symptomatic, is to try chemotherapy. Chemotherapy is quite robust, and if the chemotherapy isn't working, then you can potentially stent across the malignant occlusion, and that's usually a palliative measure. Now moving on to the lower extremities. So causes of deep central venous occlusion in the lower extremities include post-thrombotic syndrome, which generally arises from a deep venous thrombosis. So in like 30 to 40% of patients who have iliofemoral thrombosis, in the long term, they develop post-thrombotic syndrome because the disease segments on the iliofemoral veins become sclerosed and kind of become irritated and narrowed and cause there to be venous hypertension in that extremity. The venous hypertension in that extremity causes the venous valve to be incompetent and causes venous stasis, and then all the sequelae that can result from that. Other causes of lower extremity thrombose occlusion is an entity called a non-thrombotic iliac vein lesion. Lesions, these are basically external compressions from either a mass or, in the case of May-Thurner syndrome, another syndrome you should be aware of for board testing reasons, is an external compression of the left internal iliac vein by the right iliac artery. I'll go through a case of that later on, so in more detail. And then, of course, external compression from tumors. Any questions so far? So the next couple of slides will be going through techniques for endovascular management of upper extremity central venous stenosis. The first step, the first line of managing these is just a standard interluminal wire and catheter recanalization. So you would get access into the vein peripheral to where your stenosis is, and then you do a venogram to try to cross that stenosis using a combination of glide wire and glide catheter. In most cases, that's successful, and in other cases, when that's not happening, then that's usually when the stenosis is very chronic, and sometimes it's calcified or completely arthritic. Then you have to do a sharp recan. A sharp recan is basically using a needle to cross a short segment stenosis. The diagram in the bottom left shows an example of a sharp recan of a superior vena cava short segment stenosis. So this black line here is a short segment stenosis between the brachiocephalic on the right and the superior vena cava. In this example, you have needle access either through the subclavian vein or through the IJ, and you stick that needle through the brachiocephalic vein into a snare or a target in the superior vena cava. And once you have that needle access, you can get a wire through and put a stent, a balloon, and put a stent. Again, that's just like a brief overview. I'll go over a couple of cases of that in slight detail a little later in the next slide. In addition to percutaneous sharp recanalization, there's also the possibility of doing a percutaneous venous bypass. And the percutaneous venous bypass is usually a measure of last resort. It's when you have a very long segment area of venous stenosis and the patient is having severe symptoms and they're not candidates for a surgical bypass. You can attempt a percutaneous venous bypass in this case. In this diagram on the right, it's a bit confusing, but I'm going to walk us through it. In this diagram, the area of long segment stenosis is here in area D, and you're trying to get access across this into the central venous outflow system. So the first step is to get access peripherally. Let's say this is access into the right. Let's just keep going. Into the right brachial vein. Once you have access into the right into the peripheral vein, you advance a wire and catheter to the area of occlusion. At that area of occlusion, and then you leave your wire there, and then you get a venous access in the central part of the stenosis. And once you have venous access here, you have access at the area where you have my collaterals are in the IJ, where you can tunnel between the area of stenosis into the central venous outflow. That's a brief summary. I have a case later on that I'm going to describe that in more detail. So these are a couple of examples of percutaneous sharp recanalization. In this case, we have a short segment stenosis of the subclavian vein. This is a angiogram, venogram. The venogram is performed both from the SVC and from the right brachial vein. And this venogram shows that there's abrupt occlusion of the subclavian vein, and then of a short and then you see the short distance between this occlusion and the SVC. In this case, multiple attempts were tried with the glide wire and glide catheter with sheets, and were not able to cross this lesion. Hence, the decision was made to do a sharp recan. And here you see a cannula with a Chiba needle inside of it, and you're able to triangulate and stick the SVC across this area of stenosis. And once you have the needle in the SVC, you can send the wire through, remove your needle, and then you have wire access across the stenosis, and then you can deploy a stent to it. Now you see there's brisk flow from the arm down into the SVC without evidence of collateral veins. As you can see, these are all a tangle of collateral veins here on the pre, and then here's brisk flow going across without evidence of collateral veins. So this is an example of using the Chiba needle from above. My preferred approach is to actually come, if the angles of in this case the angle was more favorable to come from above. I usually prefer to come from below, mainly because if you're sticking from above, you're directing your needle towards the heart and the pericardium, and that seems more that makes me more nervous than if you have access from below. You can get a telescoping triaxial sheets up to your area of stenosis, and then you can put a snare in your target vein. And when you're doing this, you're triangulating both with fluoro. You're making multiple obliques, and you can also do a cone beam CT to make sure that there are no crucial structures where you're in the path of your needle. And then you advance your needle into the snare, advance a wire through your needle, snare that wire, and now you have through and through access. And then you can stent across that area of stenosis. Any questions about that?
Yes, there's a question, Dr. Chidubem.
Hello, Chidubem.
Sure, go ahead.
My concern about the sharp recan, to me, it appears quite risky. For instance, image A, that distance apart. How are we preventing the vascular laceration or traumatizing surrounding structures? Do we have such incidences, and how do we handle them?
So one of the main concerns, like you mentioned, is like damage to surrounding structures. In this case, you could damage the long apex. You can go through the long apex. You can go through the subclavian artery. However, we had to understand that the angle of your trajectory is very, very crucial. That's why before you pass your needle, I usually do a cone beam CT to make sure that there's no critical structures, and you also will review your CT scan beforehand to kind of get a better understanding of the 3D layout of this area around the stenosis. One thing to understand is that the subclavian vein is anterior to the subclavian artery, and the subclavian vein is the most anterior structure in the space. So if in this case, when you're doing a sharp recan and you make sure you're slightly angled anterior, the tissue that you're going through is mainly scar tissue from the area of stenosis. Another big consideration to make that I kind of alluded to earlier is that you have to make sure you're not going across the pericardial reflection. Well, the pericardial reflection is usually just at the level of the carina. So if your area of stenosis is close to or around the pericardial reflection, and honestly, I wouldn't feel comfortable doing it at all, because you can get through into the pericardium and cause a pericardial tamponade and death of that patient. In terms of kind of managing, so these take a lot of time to like triangulate and get to do successfully. But in my experience so far, both in training and as an attending, I haven't had any complications. And the main complication really that we're really worried about and can be catastrophic is the causing a pericardial tamponade from pericardial bleeding into the pericardium. But that's a very good question. It's also one of the reasons why I like going from the SVC towards the neck rather than pointing the other way. Does that answer your question?
Yes, Doc. Thank you.
Sorry, Dr. Chidubem, I also have a question.
Mm-hmm.
When we are saying a short segment of stenosis, like, do we have like a number, maybe 1 to 3 or 1 to 5, or it's just a qualitative thing? And
Go ahead.
And another question is, when you are speaking about the percutaneous venous bypass, you mentioned about we are accessing the brachial vein. Is it necessarily the brachial vein, or we could access even the basilic or the cephalic one?
So to answer your second question, I just gave the brachial vein as an example. You can access the basilic or the cephalic vein. The access at the peripheral, which I'll kind of describe to you in the next slide about for an example case, is just for you to have venous access peripheral to where the stenosis is. So that access can be on the other arm, it can be in the legs, it can be anywhere else, but you need access on the other side of the stenosis, so that you have wire through and through wire access from somewhere going across your area of stenosis and out the other side. So it doesn't matter which vein you choose, you just have to pick a large enough vein by that can accommodate the sheath that you need to place into the vein to do the procedure. And then your second question was like how long is short segment? That's a very, very good question, and is relatively subjective. I would say, for me, I would say longer than 5 centimeters is a long segment stenosis, but you also have to like kind of, it's subjective in the sense that you kind of can also see, like in this case, this is probably longer than 5 centimeters. But however, in the space where it is specifically, you can see that you most likely can get safely from the area of stenosis to your IVC, especially because it's so higher up and the pericardial reflection is not likely going to be there. And since you're going to be pointing anterior, you can still get pretty safely from there. So it's basically a function of experience and kind of talking to people who have experience to kind of guide you through that.
Thank you. There are
So I'm
also
just,
questions from the chat box.
where's the chat? Okay, so I'm looking at the chat, and so CT guided access, it doesn't give you as good enough of a live feedback in this small space, and there's so much like artifact from the like clavicle and rib that it's actually I haven't found that to be helpful. And then in addition to that, for you to use a CT guided access in this case, which is is usually a majority fluoro guided case, because you still need the fluoro to do your venogram, do your wire actions, catheter actions, deploy your stents, etc. You would need a hybrid room where you have a CT and a CT and a fluoro and an angio suite in the same room, so that you can do your your CT guided access, and then wheel the patient back to do the fluoroscopically guided parts of the procedure. And that's a good point to bring, but like most people don't have access to a hybrid room that has both CT and an angiographic machine. So if you were trying to do CT access in CT and then wheel them back, like get them off the CT table, put them on a gurney, transport them to the angio suite, put them on the new table, prep and drape, that's just too many things to do in such a short time, in such a short, like a tight space. It's just not worth it to try CT if you don't have a hybrid room. Does that answer your question, Samuel?
Yes, thank you.
All right, and then Dr. Vatican Cherry. Morning, Dr. Vatican Cherry. Dr. Vatican Cherry brings up a pretty good point that when you are doing these cases, you should like have the chest prepped to easily do an echo to evaluate for pericardial effusion at any time during the case. Like you shouldn't be like when you're suspecting pericardial effusion, you shouldn't be like rushing to undrape the patient. Like that should already be like prepped and ready to do. And then I will proceed to talk a bit about the percutaneous venous bypass. So I've only seen / scrubbed into like one of these, and in this case that I'm describing, this was like done because there was literally no other option for the patient. The patient was incredibly symptomatic. They were not a surgical candidate. And the reason why I'm bringing this up is because the patency rates for these percutaneous venous bypass is like unknown. So like it's kind of something that's done as like a last rescue. So in this case, I'm going to start from this image. This image is showing a venogram coming from the left brachial vein, showing an abrupt occlusion of at the subclavian vein with large collaterals going centrally. Access was gotten from the contralateral right brachial vein, and the wire and catheter was advanced into, at the time, what was thought to be the brachiocephalic vein on the left side, and multiple attempts were made to try to cross this lesion and get access into the subclavian vein unsuccessfully. This procedure is actually aborted, and then a multidisciplinary discussion was had with the patient's CT surgery and vascular surgery, and the decision was made to proceed with a percutaneous venous bypass. So the percutaneous venous bypass is the same beginning as this case, where you get access into the left brachial vein or the left cephalic vein or the left basilic vein. You advance your catheter centrally. You get access into the contralateral, either the contralateral arm or from the lower extremity, and get access into the proximal landing zone of your bypass. In this case, this large vessel here was actually a large left chest wall / neck collateral. So once you have a catheter in the accepting vein outflow and a catheter in the inflow, you can get venous access into this in this case, a collateral vein. So you have a like a ultrasound guided venous access in here, and then once you have this access, you also get access into the subclavian vein as peripheral as possible. And now you have access going this way. You get a wire going through your access here. You tunnel, and you first do a tunnel from this access to your access here. So you have a percutaneous tunnel between both accesses, and then you get a wire across that percutaneous tunnel and snare this the wire from the outflow down into your peripheral access on this side, and you end up having a wire coming from, in this case, the right brachial vein across the area of stenosis in a subcutaneous manner. So you're above you're in the subcutaneous tissue here. So this red arrow is your occlusion. This black arrow is access into the central outflow, and the white arrow is showing your wire in the subcutaneous tissue. And once you have this, you can either put a long sheath from your peripheral access on this side across this subcutaneous tract into the outflow. And then once you have that sheath across it, you can then deploy a covered stent across the stenosis. And that's basically what's happened here. You have access from peripheral, you have a covered stent through your tunneled subcutaneous tract into the central venous outflow, and now you have decompression of that extremity. So I'm going to pause for questions because I know there are questions about this. That was clear? No questions, no concerns? All right. All right, so that's kind of like the general gist for upper extremity venous recan. Now, this percutaneous bypass, like I mentioned, it's rare to do. I'm just including it for like completeness. The usual mainstay is just the standard interluminal wire and catheter recanalization. And then if this doesn't work, then most people refer the patient to like a institution that has high volume for sharp recan to then plan to attempt sharp recan. And then as a last resort, the percutaneous venous bypass. Now I'm going to switch gears to chronic iliofemoral venous obstruction of the lower extremity and kind of give you guys several sample cases. I'm gonna go really fast because it's getting to when I had to start getting ready to go to work. So the first is example is a recan of a chronically occluded external common iliac vein from a prior DVT that led to post-thrombotic syndrome. As you can see in this case, that we're doing a venogram from the left lower extremity, and you see as the contrast volume flows in, there are large collaterals going across the pelvis and getting into the IVC that way. There's no native iliac vein on this side. And like I mentioned earlier, the first thing to try is to get a glide wire and glide catheter, and we're successful able to get a glide wire and glide catheter up into the IVC. And in the next slide, we have a pigtail showing that we actually are in the IVC and not somewhere else. And then once you have access across the area of stenosis, you can do angioplasty. Angioplasty initially shows like improved flow, but this is like very, very athletic flow and will likely go down pretty easily if you did angioplasty alone. So the next step is to put a venous stents, and the venous stents are non-covered self-expanding stents. So you put in this case, we put a 16 millimeter, I believe this was like a Abre stent across the entire length of the diseased vein, and you can tell on the prior image, all of this is diseased vein that looks like athletic and narrowed. So you have to kind of cover these areas, because if you don't, then the inflow from the lower extremity will be like suboptimal, and with suboptimal inflow from the lower extremity, the stent itself can go down. And now with the stents in and ballooned, you see brisk flow from the lower extremity into the stents without any residual collaterals in the pelvis. Excuse me. The next case is stenting for tumoral compression. In this case, we had a patient who had metastatic neuroendocrine tumors that was compressing the intrahepatic IVC to the point where they had severe lower extremity pain and also like starting to get like venous ulcers. And this was like a palliative measure to kind of decrease their pain as they were going into palliative care for their metastatic cancer. In this case, you can see again, we're doing a venogram. There are multiple collaterals in the pelvis. We see severe narrowing in the intrahepatic IVC. Very important to note for this is that the narrowing alone is not what determines if you're stenting. You also need to take pressures. So we took a pressure in the infrarenal IVC, and the pressures were like very elevated at like, I think it was like 25 or 30. That's very high for venous pressures. Once we put the stent in, the stents shows improvement in flow, but most importantly, they're still narrowing here, but the pressures decrease very significantly down to about 5 or 8, and we thought that was adequate enough to give them good outflow and palliation from the external tumoral compression. So May-Thurner syndrome, this is an example of May-Thurner syndrome treatment. We have a venogram showing a very, very short segments narrowing of the common iliac vein with still flow going into the IVC. You're able to easily get a wire across this. Before you stent, most people do intravascular ultrasound to measure the actual diameter of and extent of compression, and also because if it's very, very easy to show like possibility of like it's easy to show May-Turner syndrome on anybody. If someone is like volume down, then you can easily determine that you can easily, at least with pictures on venogram or on CT, kind of determine that they have May-Turner syndrome. So it's very important to do IVUS to kind of actually measure the volume of the IVC at the narrowing and make sure that it's greater than 50% asymptomatic. And this image is just showing the significant narrowing. This is the common iliac vein. This dark structure right here is the right common iliac artery that's compressing the vein. And then you see after stent placement, there's a significant increase in luminal gain at the area where the artery is compressing. So just a brief overview of venous stents. These are all the venous stents that are available in the market. They're all relatively interchangeable, at least right now. There's a point where one of them was noted to have had a recall and was because it had a lot of like fracturing, especially when deployed at the inguinal ligament, but they have since been put back in the market and seem that they're been doing well. So anticoagulation, platelet therapy after you put these patients, after you stent these patients is like kind of dealer's choice, to be honest. There's a lot of variability in how people like do give antithrombotic therapy. Some people use Brilinta, some people do dual antiplatelet anticoagulation. It's kind of tailored to each individual based on like their other risk of both bleeding and risk of post-traumatic syndrome and risk of coagulation. If the patient is having these symptoms because they have some underlying anticoagulable state, then you need to put them on dual antiplatelet therapy. However, if the patient is like has a NIVL, like a May-Turner syndrome, then sometimes it's safe enough to just put them on like an aspirin 81. In either case, if the inciting problem was DVT, they still need the anticoagulation treatment course for the DVT, either 3 months or 6 months, depending on if it's unprovoked or provoked. However, this anticoagulation platelet therapy that I'm discussing in this slide is beyond that. Like, what should you do? And it's actually not truly clear. So a couple of trials to be aware of. There's the C-TRACK trial, which is looking at post-thrombotic syndrome in the US. And then there's the BEST trial, which is looking at both post-thrombotic syndrome and patients with May-Turner syndrome. Both are randomized clinical trials to not receive versus receive iliac vein stenting. And both are accessing for like the cost effectiveness of doing these procedures. Sorry, I had to rush the rest of the talk. Any final questions, concerns? Dr. V, do you have any comments? I know you always do.
No, I mean, yeah, great talk. Yeah, it shows you kind of the complexity of venous disease. I do think the important things to understand are, the role of the kind of the VTE or DVT is anticoagulants. So, things to think about are, is it provoked or unprovoked? And that changes your whole kind of long-term treatment algorithm as far as anticoagulants. So provoked is kind of post-surgical, post-trauma. So it's kind of a likely, very aggressive anti-inflammatory response, or inflammatory response will cause it. And then unprovoked is really something else is causing clotting, something that's usually, or that can be seen in the blood, or cancer, something of that nature, where you're going to have indefinite anticoagulation, or at least 6 months to a year of anticoagulation. And the risk of recurrent VT is pretty high. And then the different types of anticoagulants should also be you should also be cognizant of. Most places will have warfarin, but if you check INRs and understand the role of Lovenox or low molecular weight heparin, and then finally DOACs or direct oral anticoagulants and direct thrombin inhibitors and factor 10A inhibitors, and how they play in and whatnot. And there's going to be an increasing role, probably worldwide, of these agents. So you just become familiar with that as well. And then just know your hypercoagulable workup. I'm not sure what the kind of predisposition is there, but like at least here, factor prothrombin 20210 and factor 5 Leiden are fairly common. And so you usually work that up. And also we will look for in these unprovoked VT or arterial clot or extensive venous thrombosis or unusual venous thrombosis, different mutations, including antiphospholipid antibody syndrome, which is like a triple check, beta-2 microglobulin, lupus anticoagulant, and anticardiolipid antibody. And then, protein CNS and antithrombin deficiencies are all important things to just be aware of. And in the right patient check, not every patient, but in the right patient check. And that will usually require indefinite anticoagulation. If it's an antiphospholipid antibody syndrome, then these patients will benefit from Coumadin or warfarin and not a DOAC. So again, these nuances matter. So to tell you what the likelihood of recurrence is, what the duration of anticoagulation should be, and what agent should you utilize. And in the cancer patient, really, typically it's been low molecular weight heparin, so the injectable Lovenox is better than warfarin for a reduction in recurrence of VT, venous thromboembolic disease. And then in the cancer patient, that is, the DOACs have also shown a role, including Pixaban with the ADAM and Caravaggio trials, and then even rivaroxaban when compared to Pixaban in a randomized fashion in the cancer patient. So again, just be familiar with this when you're dealing with venous disease. Understand clotting mechanisms and clotting and how to reduce that. And I usually put them on, you're trying to improve their symptoms, as you said, the PTS, venous claudication, the venous ulcers. So compressions, if their arterial flow is good, is important. Multi-layer wraps to kind of improve the healing, good wound care. And then, like you said, it's the deep system, but also the superficial and perforator system may have to be also addressed depending on what you're dealing with when it comes to a wound. And then ambulation. I try to encourage ambulation because the calf muscle it generates 35 to 50 millimeters of mercury pressure. So the more they ambulate, it reduces that kind of recurrence in theory, and improves their functional status, because ultimately that's what you're trying to do. So I do 3,000 steps in a month, 5,000 in 2 months, 7 to 10,000 in 3 months, and advocate 10,000 steps a day. So just kind of generate that when you're talking to patients. That's all I have to add. I don't know if anyone else has anything to say. But thank you, Chidubem. That was great.
Yeah.